you. And let's start out with some team introductions. Renee, if you could introduce yourself.
Bonjour, Renee Bolio Banks, Indigenous Cause, Jaganashimang. My English name is Renee Bolio Banks. Zibikwe, Indigenous Cause Indigo. My spirit name is River Woman. Zagasqua, Jamaica, Gandunjaba. I'm from Leech Lake Nation, and Bagizi and Dude, I'm from the Eagle Clan. I've been at NACC for almost 4 years. I'm one of the elders and residents working with our relatives here. That's it. Thank you.
Thank you. And Lindsay?
I'm Lindsay Kinkuni. I'm the Community and Tribal Engagement Specialist at NACC.
And Dr. Robbie?
I'm Kari Robbie. I've been in NACC for, I think 10 years, and I am a family practice physician and addiction medicine specialist.
And Michelle?
Hi, I'm Michelle Corcoran. I've been at NACC for 4 years. I am the MAT nurse manager for the MAT program, both direct prescribe and dosing.
Thank you. And my name is Tina Monnier. I am the harm reduction program supervisor here at NACC. And then quickly, Dr. Stately, if you could introduce yourself.
Sure. Good afternoon, everyone. My name is Antony Stately. I'm a citizen of the Oneida Nation of Wisconsin. Great citizen, our descendant of the Great Red Lake and White Earth Nations of Minnesota, and also the executive officer of Native American Community Clinic. And I'm honored to be here. Thank you.
Thank you. And so we'll just quickly, before you share your slides, Dr. Stately, we'll go through some housekeeping for the group. So yeah, today we have Dr. Stately here. So on Monday, next Monday, it is National Native HIV/AIDS Awareness Day. So we're having Dr. Stately on today to give his talk on HIV, homelessness, opioid overdose, hepatitis, and COVID, and what we call the ongoing syndemic affecting the Native American community. And for those who are new to our ECHO, we are a Native American Community Clinic. We're located in South Minneapolis on Franklin Avenue. We are a federally qualified health center, and we were established in 2003. Currently, we offer primary care, medication for opioid use disorder, and MAT, so Suboxone and other medications, infectious disease intervention and treatment, social service support, dental, behavioral health, intensive outpatient. We have elder care and traditional healing services, as well as a range of health promotion and maintenance programs and harm reduction outreach services. And Lindsay will take it from here to talk guidelines and announcements.
Yeah, so some guidelines. Please know protected health information during the session. If you can mute yourself if you're not speaking, that would be great. You're always welcome to eat your lunch during this time. Really important, if you could let us know who you are in the chat function, name, title, organization, and especially your email, so I can get the post survey out for people that need the CEU credits. And then we also invite you to use the chat to ask any questions or comments. And then some announcements. So a reminder, we meet the first and third Wednesdays of the month at noon. Some upcoming sessions. So next one will be April 5th. With Dr. Kaz Nelson from the University of Minnesota, and she'll be talking about borderline personality disorder and treatment. And then we'll have another session on the 19th, which will be to be determined. This is just a list of a few other ECHOs that we recommend. And then we do offer the CE credits. So it's important if you could leave your email info with me and I can give you the survey. And then case presentations. If you have a story or difficult case to share, it makes for a great discussion. So let me know in the chat, or you can email me if you have something to submit. And then with that, I will stop sharing and hand it over to Dr. Stately.
There you go. Can people see that screen there? Yeah, I can't hear anybody, so I hope you can hear me.
Yes.
Okay, awesome. Okay. All right, well, good afternoon again. So I'm gonna start from here. Why is that there? So one thing I was gonna say was, one thing I didn't say in my introduction, and I'll say it now so that, you know, and it's, I know you just said not to share private health information, but, it's mine, so I get to disclose it if I want to. Uh, I forgot to mention in my introductory comments that I am a person living with HIV. I have been living with HIV since 1991, I think. Anyway, it was right after the 80s, which were fabulous, by the way. So, I've been living with HIV for, I don't even know how many years it is. 40, 37, 36, 33, something like that. Anyway, so long that I can't even remember. And so I wanted to disclose that information, and since it's World AIDS HIV Awareness Day, I think it's really important that, I take it to be a critical piece of my responsibility and my role, not just in the role that I have here at NACC, but also just sort of my as being a member of my community, to be really transparent and open about my HIV status. And I think I know that that stigma is a real thing. I've had to deal with that a lot throughout my lifetime. And I also have, I had to navigate that space as a young man. I think I was 26 when I first became HIV positive, 27, something like that. Stigma and the stigma surrounding HIV and all of the things that sort of related to HIV were certainly things that really took up a lot of psychological, emotional, and spiritual energy for me in my early life, and those are real things. But I think it's also important now at this stage in my life to be really transparent about my own experience, because I think that has an opportunity to benefit so many people in our community. People who have a lot of the same circumstances in their life, perhaps, that I have, but also who look like me and who are from my community. So I wanted to share that piece and be clear about that. I think it's important to be forthright for me personally. So I think of the ongoing syndemic of that sort of confronts our community that we serve here specifically in South Minneapolis, and also within the state of Minnesota. And I know this is true in so many other Native communities, especially many of the urban areas where Native people find themselves in similar situations and conditions that we here in South Minneapolis see with our relatives, which is these intersecting epidemics and that we see sort of converging and having a significant impact on our communities. And those are HIV and hepatitis C are significantly greater, have greater impact on our community and here in South Minneapolis than any other community or ethnic minority group in the state. We have seen a significant rise in HIV cases over the last 2 years. And the intersectionality between those cases and the hepatitis C in respect with IV drug use and the vulnerabilities in other areas around like being houseless also has a big role here. And then the impact of a worldwide pandemic on top of those things. And then the ongoing increasing sort of like situation with opioid use disorder and fatal and non-fatal overdose. These 4 things kind of converge to make things very, very challenging for our community. They also happen to, operate from within the background of 2 really critically important things that actually sort of like both create the opportunities for these things to happen and also sort of kind of keep them, these things feed them. And these are systemic racism and structural, deep poverty, structural level things that really prevent or create significant challenges for us collectively changing this narrative. And so I think it's important to remember that, this little white circle here that says poverty and racism and its background is the thing that's in place that operates in the background. So between the times of 2018 to currently, it's probably even longer than that. I didn't change this side. It's closer to like 55 months now, I think. In Hennepin County and Ramsey County, so the Twin Cities area, which was the area that NACC serves, amongst the people who inject drugs, who are also houseless or living unsheltered, particularly in areas of the Phillips and neighborhood encampments, followed other encampments throughout the Twin Cities. We've seen a significant rise in the number of Native people who have become HIV infected, and it is a number that has continued to rise over the last couple of years, and it has not gone down, which is some of the things we're going to talk about today, which is challenges before us. We also continue to see significantly higher rates of overdoses in the state of Minnesota and Native Americans and African Americans overwhelmingly represent a significant portion of those people dying from fatal overdoses. And we also represent a very high percentage of people who are impacted by non-fatal overdoses. One of the things that I think that we don't always talk about very often, and I think it is an important thing for us to sort of kind of keep in the back of our minds, which is the percentage of people who have a non-fatal overdose who actually will then go on to have a subsequent overdose or 2 are much more likely to die within a year. So if you have a non-fatal overdose and you remain outside of sort of intervention or treatment, you're much more likely to die within the next 12 months from a subsequent overdose. And that becomes an important part of understanding why things that we do, like harm reduction services and engaging with people where they're at, not waiting for them to come into big, large health systems or big or into programs seeking help, trying to get connected to people right away when they and doing a better job working across a system of care to get connected to people who have a non-fatal overdose as quickly as possible. Is we do know that the rate of mortality goes up significantly after one non-fatal overdose. I want to remind people that it was only, and here we are, it's March 2023. And it was around this time that we started to see, in 2018, 5 years ago, the wall of, the cluster of tents that began near Franklin Avenue in Hiawatha, which is 4 blocks to the east of NACC, where eventually by the end of the summer, so by August, September, we saw one of the largest houseless encampments of people ever in Minnesota's history emerge over a period of about 6 months from March to September. That encampment became known as the Wall of Forgotten Natives. And at its largest point of census, it was estimated to have between 300 and 400 people living in the encampment. Multiple generations, children all the way up to elders, were living in that encampment. And if you had ever had the opportunity to walk through or see information about the Wall of Forgotten Natives, I have some pictures here. I want to remind you that that at its biggest and the most critical moment, it easily rivaled the images that you would see in any developing country in terms of the conditions in which people were living. We had people living outdoors in the severe and inclement weather, with no heat, little food. In the first initial months, they had no bathrooms. They had no running water, no way to like take showers or clean themselves or wash their hands. Or, we had people living in encampments that had, severe conditions that were highly infectious. So a lot of vulnerability to hepatitis A, other forms of infectious disease that were just sort of like really set out for some really terrible conditions for our community. And, that Wall of Forgotten Natives and all of the things that were sort of kind of going on within that, 1 block strip of grass along Hiawatha Avenue, garnered not just attention from the city, but also the statewide attention, regional attention, national attention, and in some cases, international attention. For about 6 months, these were the headlines that were grabbing attention: people dying from multiple overdoses, a baby, I believe towards the end had died in the tent. There were all kinds of conditions in which, this was national news, international news at the time. What's compelling about this is here we are, and I want to remind people like how the community and the city and the county and the state and a bunch of other community organizations were able to come together and work collaboratively and collectively to sort of house those 400 people. Created a navigation center where people got critical life-saving and life-supporting sort of interventions and support. And it was really, when we reflect now, 5 years back, we had done collectively a Herculean effort, something that no other, many other cities and many other communities were not able to accomplish. So we should be proud of the work that happened in response to that, but we should also not forget that today, Native people still represent about 1/4 of the houseless population in the state of Minnesota, and we're only 1% of the population, between 1% and 2% of the population. That is a significant the disparate number. Dr. Robbie likes to say, remind us all that the opposite of addiction is not sobriety, it's actually connection. And one of the things I think that was beautiful about that response that we had across the community, across all these government agencies and other folks that were engaged in the work was that, there was a lot of connections that were made that are still in place today. One of the things that, so the inequities that we see in the Native community today, with respect to HIV, with respect to other infectious diseases, and this endemic that is driving much of this work or much of these challenges in our communities, these are born out of inequitable access to, in many ways, basic things, life, living supports or life supports that we all take for granted every single day, right? And many of the sort of more privileged parts of our community and our state take for granted every single day. A stable living environment, a home to live in that has heat, that has running water, that has the ability to sustain one's well-being and their families. Other things as well. A lack, an ability to, houselessness, if you think about it, is the very foundation of well-being, because if you don't have a house, if you don't have a place to live, shelter from the environment, shelter from the elements, those kinds of things, and a space and place in which you can sleep, you don't have to worry about all kinds of conditions, you are going to struggle with going to work, you're going to struggle with completing your education, your children will struggle with completing their education. And we know that that specific situation contributes greatly to people not being able to access healthcare and benefit from intervention. Contributing factors that made the issues in HIV in our communities and the increase probably had a lot to do with our pandemic, which I think there's a lot of assumptions that folks make because we're walking around out in the world not wearing a lot of masks. I don't see a lot of people wearing masks when I'm out in public. And if I'm honest, I don't even wear a mask when I'm out in public unless I'm in a small space that's going to actually, I don't know why this keeps moving forward, sorry. So I think lots of folks operate under the assumption or the belief that the COVID-19 pandemic has ended because we're not in a state of emergency anymore. In fact, actually, the COVID pandemic is more like an endemic now. So it's likely to be here. It's becoming a lot like, I think in some ways, that way that people think about HIV as well, right? Remember back in 1980s, 1990s, that's certainly when I was a young man, in the late 80s and early 90s, I was surrounded by friends, people I loved, who would get HIV and die within weeks, months of becoming HIV positive. And it felt like a crisis then, right? And then we many of us, not all of us, got the benefit of some life-saving and life-sustaining interventions like the better class of drugs or medicines that helped us sort of like continue to do better. So we relaxed and we got used to the idea that it wasn't an issue anymore. And so I think in some ways I see people operating from the same assumptions about COVID. The challenge with that is that, as things move from a pandemic to an endemic situation, the people who benefit or who are able to continue to sort of do well in that type of a scenario are people who have access to resources, stable living conditions, money, so they have the ability to pay for some things. They have access to other resources, healthcare, insurance, those kinds of things. And that makes communities like ours that we serve much more vulnerable, right? They don't benefit from those things as well because we have this invisible cloak behind us. We're living in a world in which, there is just inequities baked into structures. And until we sort of kind of like that graph I showed you at the beginning, until we sort of like move those things forward and make them much more transparent in the ways in which they show up every day in our lives, in our clinic, externally out in the community, externally out in larger systems, until we start to expose those things and make them more noticeable and more real and more transparent. That's the food that feeds things like syndemics, right? It continues to sort of become this endless loop that we don't pay a lot of attention to. And those are the things that do things like increase substance use, mental health conditions, increase socialization, make people feel like they don't matter. Many of the conditions we've been talking about, and like HIV, IV drug use and opiate use disorder and substance use, also mental health, depression, anxiety, trauma. These things are also impacted greatly by stigma, and also contribute greatly to sort of like increasing people's risk for actually becoming HIV positive and acquiring those conditions. Many of these conditions are caused by despair and hopelessness, and until we sort of attack some of the bigger issues around structural interventions, as well as seeing people, and providing direct care to them, we will continue to be struggling with some of these issues for a while. In our clinic, we about 3 or 4 years ago, probably, Rob, correct me if I'm wrong, but about 3 or 4 years ago, we made an intentional decision to move towards increasing our capacity to deliver HIV care to our relatives in our community, because in direct response to what we were seeing phenomenologically in our community. This is even before we saw data, really, quite frankly. And one of the challenges that I will say about this specific pandemic issue or syndemic issue is like having access to real clear information and data about the way in which your community is being impacted by certain conditions is a really critical piece to this conversation and puzzle. I've had challenges in the past, and I have brought the state and other entities to task by not being more transparent about the rate of infections and those kinds of things, and its impact on our community in a more expedient and transparent manner, because not having information about that until it's 1 or 2 years down the road does not help us in real time. So one of the things I think that we did as a clinic, and we did it well, is we saw people coming into our clinic testing positive for hepatitis C. We saw those, our anecdotal experience was we saw an increase in these numbers. Anecdotally, we saw an increase in people coming in testing HIV positive, right? And so we and Dr. Robbie, in her infinite wisdom, she really led this charge, quite frankly, in our clinic, and I supported her wholeheartedly. I might have actually pushed her to do it. I think I might have said, "Hey, I think we should do this. Don't worry, I'll be right behind you." Although I don't practice medicine myself personally, but I'm her biggest champion. What we did was we started working with MATEC a few years ago, and we started to build the capacity within our organization to become an HIV care provider And we were one of the first federally qualified healthcare centers in the state of Minnesota, if not the only one, I think, at that time, that started to deliver HIV care within our federally qualified community health care centers structure. So that was in 2019. Here we are almost 5 years later, 4 years later. We're well on the track to becoming an HIV Center of Excellence through our partnership with Midwest AIDS Training and Education Center. They gave us a practice transformation grant. We were awarded together in partnership through HRSA, a HIV Center of Practice Transformation grant, which has significantly impacted our ability to train our staff, create a plan for implementing broader HIV programming. And over the last 3 or 4 years, we have significantly expanded that footprint. Which I personally, and as the leader of the organization, I'm very, very proud of the work that Dr. Robbie, Michelle, Tina, and the rest of the harm reduction team and the people who do HIV care and HIV support, including prevention work, have done in our clinic. I'm tremendously proud of them. Here's our strategies that we have sort of engaged in to reduce barriers to HIV care. We provide same-day antiretroviral therapy, so ART, access to HIV antiretroviral drugs the same day that they test positive. We're trying to start them on ART as soon as possible. We also provide same-day PrEP. So it's integrated into our primary care services. We provide a whole range of wraparound services, including HIV case management, benefits navigation, spiritual health, spiritual care, dental care, behavioral health care, and of course, immediate access to medical needs. We now have, I think, Javon is our non-medical case management link to all people who come through our clinic who test positive or just come to us for the clinic and they need HIV case management. We have those services on site now. And then, of course, we have a very robust harm reduction team, which delivers SSP supplies and education. Our approach to that work writ large, not just in this clinic area, but across the clinic. We work really hard to meet people where they're at. So a low barrier, non-judgmental approach to this work and all the other work that we do related to our relatives that are sort of impacted by these conditions. We prioritize the building of relationships. I think 4 years ago or 5 years ago or so, right around the time, I think, as we were dealing with the Wall of Forgotten Natives and all of the work that was sort of precipitated by that event. We, as an organization, I think we took an intentional step to ask ourselves, you know, how might our work and how might we move forward addressing these conditions in our communities differently, and how can we advance the work in harm reduction and low barrier care. And we have made an intentional effort over the last several years to approach our care to patients and to the people we serve, our relatives, by making an intentional decision to show up in that space and place, in all spaces and places, and try to be the best relative we can be to everyone, including the people that walk through your front door and also the people that they are in relationship with. Strategies to reduce barriers to general care. Like I said, we really prioritize these. Our strategies are really organized around trying to reduce as many barriers to care as we can for people, especially the most vulnerable and the most people call them marginalized. I say they're disinvested in. So the people in our community who sort of kind of are on the fringe don't have a lot of access to a lot of resources. These are the people that are we approach in this way. I think we actually apply these principles to pretty much everybody we serve, but it is a particular way of approaching this community, this part of our community, this part of our population, these relatives, that help them to sort of step into a space that's really hard to sort of step into. And so the other piece I think that is really something we have bitten off, and we are deeply embedded in this work is the public health approach that we take to sort of this work, which involves obviously outreach and community health, but also we have significantly upped our game in providing input into structural level sort of interventions like policy work. Many of myself, Dr. Robbie, other members of our team and other members of our organization are involved in policy level discussions that happen in all sort of forms of the government and other organizations and agencies that provide us an opportunity to sort of leverage our expertise and our knowledge and our wisdom and the experience we have with our community to sort of contribute to improving the conditions that will lay the foundation to improve some of these large issues that are confronting our community every single day. And so we have significantly built out stronger partnerships with like-minded individuals who share a philosophical approach. We have strong collaborations with maybe not the writ large, the huge health systems themselves, but we have what I would say confederates within large health systems that share a philosophical approach to low barrier care and harm reduction, and why that's such an important piece to sort of solving these conditions. And slowly but surely, we're sort of kind of winning over more people from with that approach. And so, one of the things I wanted to say as a reflection point for me, as I think back now, here I am, I'm a 60-year-old man now, and when I was 20 years old, confronting, I moved to Los Angeles when I was 23 years old, and I was dropped in the middle of like one of the what I would call the boiling pot of HIV in our country. Didn't have a lot of information or knowledge about what HIV was. Didn't have a lot of understanding about my own self and my own life in relationship to these large systems. Had certainly a phenomenological sort of like response or understanding of like what racism looked like in my life, but didn't have an understanding of how that was operative in impacting my own health and well-being. That was only something that I grew into through my own through lived experience, right? And I can tell you that like those were not conditions. I wasn't houseless, but I was living in Los Angeles and only making $8 an hour at the time, and barely afford to pay my rent and a few other things. And so when I reflect back on my life as a young man, I realized that the conditions that were around me at that point in my life, and I was far, far away from any family and anybody, and not connected at all to the systems, the people that are the community. I didn't have a community to rely on, any of those things. Those things made me very, very vulnerable to becoming HIV positive. It made it very, very difficult for me to navigate and negotiate space and relationship. And as I think back on the things that made me very vulnerable in that part of my life, I can see really clearly the way in which our community is vulnerable. Those things that are true 40 years ago are true today. And so I think one of the things we try to do in our clinic is that we try really hard to address those things really directly and think through how do we do those things by reimagining what care looks like, by actually caring about the people that we serve, prioritizing care over health, which is a little bit of an odd statement. So, but I think that's our approach, and I think we do a really great job with that. Anyway, that's the end of my presentation. We have a better sign than that now. We should take a new picture. But any questions and conversation? Stop sharing. Well, hearing that, I'm going to leave. No, I'm just kidding.
Yeah. So we want to know where the better sign is.
Yeah, where's the banner?
I thought we got a better banner. We absolutely got a better banner than that one. That one was like from 4 years ago, I think, 3 years ago.
Longer.
Yeah. Yeah. So that one's the one that has isn't that the one that has Boujou spelled wrong? Yeah.
Oh, no.
It said Boujou, I think. It said
Boju, oh,
It had like an extra O in it. Somebody penciled one in. Anyway, questions?
Yeah, so yeah, any questions for Dr. Stately? It's such a pleasure to have you presenting with us today and to hear your perspective on all of this.
It's disheartening to me that, like, you know, that little piece about how, like, you know, the conditions that were true for me 40 years ago, in some ways, you know, maybe like, you know, maybe aren't true for a lot of our population that are sort of like housed and stable and the other things, but like this is an overwhelming reality for so many of our relatives in our community. So that to me is like, it's heartbreaking, actually. It's heartbreaking to me. So yeah, so we've done some really great work, but we have a lot more to do.
Yeah, and I think that part of doing the work is to recognize, you know, all of the incremental successes that our relatives have they are still meaningful, you know, like in the context of this overwhelming work that we do.
Yeah, and there's so many, like, even with so I think one of the things that we think about is, you know, most people, I think, when they think about like who's vulnerable for becoming HIV positive, like who is being impacted most by HIV, you know, overwhelmingly, like when you just look at the pure numbers, like the people are so interested in like, well, how many people, you know, it's like the challenge is that, like, you know, Native people represent such a small number of the population. People don't even oftentimes calculate like how many cases there are that are Native. They don't even report them a lot of times. We've had to work really, really hard with the state to make them disaggregate data and report that information to us. Yeah. We've had to, like, I remember about 4 years ago in a planning meeting I was in around when we were working on developing a statewide prevention plan, there was somebody who I will not name publicly who said in the meeting, why are we even talking about Native American people? They only had one HIV case in 2016. And I remember becoming really incensed, first of all, because all of a sudden I felt really invisible in the room, right? These are the ways in which Native people and other people who are, you know, who are part of the fringe, part of that marginalized community get made invisibilized, right? That's part of like what actually sets the foundation for some of these things to happen. And I raised my hand and I said, with all due respect, I don't think you understand how prevention works, right? Prevention is not about taking care of what's happening right now, phenologically. It's about looking down the road and helping us to understand where are we headed and what can we do to sort of like avert the disaster that's up ahead. That's what prevention is about. And I might remind you that Native people represent an overwhelming number of the population who are struggling with IV drug use, which I don't know if you know this or not, but that's one of the routes when people become HIV positive. I think in about 3 years or 4 years, we're going to be facing a pandemic. And I don't have a crystal ball. It's just logic, right? I knew that was going to happen. So I kind of am not surprised where things are, but I'm heartbroken and pissed off about it, actually, quite frankly. So.
Yeah, and didn't we, Dr. Stately, just like the most recent overdose non-fatal overdose data, like if you look at the data, they say, oh, who is most going to be impacted by this, and I think that if you just look at the pure numbers, it's white males from the age of 30 to 34, not taking into account that white people are 82% of the population, and so when you're looking at pure, so that's.
I was actually thinking about that email as we were talking, and how the email is like, oh, white males between this age are most impacted. And I was like, wait a minute.
Which is actually the new data is like, I think if you calculate it, Native people are 13 times more likely to have a non-fatal overdose.
Yeah. And like think something closer to like 17 times greater to die.
Yeah. So I'm noticing that Michael has a question.
Yep.
Oh yeah, so I was just wondering, like for natives living in more rural areas, where they are more affected by drug use and HIV, if you guys are aware if like Indian Health Services are making an effort to offer MAT programs, or where they left, I guess, is my question.
Well, I think that two things. One is, I don't know that I would say that they're more vulnerable. I think they have a lot of vulnerability as well. But I think that part of it is that I'm not really clear what's happening. Like, first of all, like one of the things we have to understand about tribal communities is that some tribal communities have IHS operating and driving their healthcare systems on tribal lands. A lot of other tribes are 638 compacted, and they take responsibility for their own health systems, right? And we have 11 tribes in the state of Minnesota, and each tribe has sort of different sort of healthcare structure. But part of that is that there is a national HIV strategy for IHS, and IHS sort of has their sort of strategy in place and what they do. I think generally speaking, like my understanding of their strategy is that it's more clinically focused, and it doesn't have a lot of the approach that we have in it, that the way that we approach the work, right? And I don't think that it's like to say that they're not doing it right. I think it's just like they have a specific model in which they deliver care. They're a federally funded direct care model that is different than a community health center model, right? We have a little bit more flexibility by which the way we do our work. So that's one thing to sort of kind of remember. I think that there are things that become, so some of the things that we were talking about that are sort of like the things that make our relatives more vulnerable, they become significantly perhaps have much more, some of those situations have greater impact or greater influence on the outcomes or the conditions of those people's lives and make them more vulnerable when you also layer in like the things that come along with ruralness, like the isolation, the lack of, like, if you don't have a provider that can sort of do this type of care for you or provide these kinds of service to you that are nearby, they're 25, 50 miles away. Some people in the northern parts of the state, they have to drive like 2 hours to get to their closest provider. That of course is going to make things much more challenging, right? So then the model of like outreach and care and intervention would look differently, right? And might be much more challenging. I happen to believe that one of the reasons why we have been so successful in our work that we've done in our community around this work is that we have taken a lot of intention in building out strong partnerships that with like-minded people who share our philosophical approach to doing this work. In many ways, in many situations, we lead this work, but in a lot of ways, we are walking alongside of people who have a lot of the same approaches to doing this work, and we work collaboratively and strategically on this work. And this is the way that you get those things accomplished. This is the way that you move the needle on in community health, is by not trying to do everything yourself, but finding people that think like you, work like you, that have the same passion and mission, and sort of kind of tackling problems together. And we've done a great job of that. And I think it's one of our biggest strengths. So.
I would add to that, that's part of the reason we're doing this, is to share the information and things that we learned and are continuing to learn, and then providing support for other organizations, clinics, to kind of do that same thing. And, we have people join us here on ECHO and just learn a little bit and take that back to wherever it is that they work. And then hopefully, change minds, provide education, and kind of share what we're doing.
Yeah. And, the ECHO serves the entire state of Minnesota. And so one of the things that this is what we're doing. We're trying to share our knowledge, wisdom, and experience. And I think there's an appetite sometimes, like Dr. Robbie and others, we see ourselves as a resource to the community as well. So you have additional thoughts or ideas or questions, and you want to ask those things. I think there's a way to communicate that information to the team here. I think that all of the emails probably go to like an email address that you guys provide at the end. And, that's cool. I think this is as much our responsibility as providing, vaccines is as important as delivering care. It's our job to sort of also try to help build the capacity of the larger system to sort of address our relatives in an improved way, and to partner with people on that, even if it means talking with you for 5 or 10 minutes about problem solving. Sometimes that's a really important contribution. But this is the way you tackle health equity issues, is that you don't think of yourself as a silo. You think of yourself as, a big, long circle of a big, huge circle of people that are sort of kind of trying to tackle the same thing. And we all have our part to play. And I happen to believe that I have the best team on the planet, which none of you are allowed to try and take from me. So if you do, I'll find you. No, I'm just kidding. So
Thank you, Dr.
I'm happy to share them. I just don't want them to leave me. So it's just, you can share them. You can pick their brains, ask for advice. But yeah. I'm still a little Indian boy that grew up on the res and grew up in boarding school. And if you try to take my toys, I get really, really stingy and mean. I'm joking. Anyway, thank you for having me. I really appreciate it. I hope you all have a great day and get out and enjoy one day without snow.
Thank you.
Thank you, Dr. Stately.
Thank you. And I just wanted to mention, when I send out the email, I do send out our YouTube channel, the Midwest Tribal ECHO YouTube channel. And then as well, you can contact me if you have any questions or comments. So, thank you so much. Just wanted to remind you all, our next session is April 5th, and that's with Dr. Kaz Nelson. She's going to be talking about borderline personality disorder and treatment. So hope you can join us again. Thank you.
Thank you. Thank you. It's been a privilege. Bye.
Bye. Every single person.